最平嗰個。
最平嗰個。
Hi, everyone. Thanks for coming. We'll wait in a little bit. We'll start in a few minutes. Hi, thanks again for coming, everyone. Probably wait another minute or two, and we'll start. If, you can use the, use the chat to give any questions or comments. Use the chat or just unmute yourself and speak up. Try to be very interactive. Should be time to do that. All right, so we'll get started. If you have any questions, comments, go to the chat or you can unmute and just ask. So we wanted to cover a little bit of stuff related not to just the brain. I think we've neglected a bit of the facial head and neck vasculature, and not by design necessarily, but I think we need to show that. And this particular topic, it might seem a bit esoteric, I guess, but I don't really think so. This has been gaining some prominence. Probably there's about 50 face transplants that have been done so far across the world, depending on how you count them. And they're picking up. Certainly it's a team endeavor and takes a lot of resource and so forth, a lot of expertise. And we in the vascular world play a critical but small part in this. There's so many aspects of what goes on there. But it is something that I think we should be familiar with. You may have been involved in one or might be in the future. So we'll just review some vascular aspects of that. And it's a window also to talk a little bit about the anatomy of not just related to transplant, but anatomy in general of that area. So far at NYU, we've done these three, and it's really, behind each one of these is obviously a story of tragedy and perseverance and effort and team. And I think, there's a range of reasons why somebody might suffer like a horrendous injury like that might lead to consideration of face transplant. And one of the reasons is, if you look at these pictures, is that it really works, or at least for sure it works better than the alternative, which is kind of these reconstructive techniques that don't involve transplantation. Depending on the injury, they are really limited in what they can achieve. Whereas the transplant, a lot of them have been judged by the recipients and in general to be successful. And so we'll talk a little bit about just kind of the range of what is done and what the vascular stuff there needs to be. This is a picture of the team that was involved in the latest transplant, as you can see, that took place within last year. And it's a huge team. Dr. Rodriguez, who is the man in the front here, is the leader of the team. He's the lead transplant surgeon. And a lot of what happens here is really as much about surgery and technical aspects as it's about team building. Like, he's an amazing team builder. And it takes a huge team really working as a team to make this happen. A lot goes on in terms of preparation. So this effort started about a year before we ever did our first one, to just line all the ducks up and make sure everybody knew what they had to do when the time came to do it. In terms of vascular stuff, I want to talk a little bit briefly about what this entails. Basically, what needs to happen is from the donor, the tissue is taken depending on how extensive the transplant is. There's partial face transplants, total face transplants. It depends how you kind of classify them. Some involve some people's hair and ears have been burnt off, for example, so they need more tissue than someone who, say, has a face per se. So there's all these kinds of important details. In terms of vascular things, you can see what this involves. Usually there's a little bit of debate about how many anastomoses you need and this and that. We get into this a little bit. But essentially what you need is at least one anastomosis on each side, one artery, one vein, total 4. They can be, depending on what you're plugging into what, or what they're plugging into what, you can see different kinds of combinations. Like if you're taking the ears, you might need some of the vessels from the back or the scalp. You have to plug into those. So they have to dissect the facial artery out, on the STA sometimes, or parts of the occipital, and attach that to the ECA. So usually there's an ECA end to side or an end to end anastomosis that happens. Now, very importantly, we'll talk a little bit more about this, but very importantly is the vein part. Of course, everybody understands you need the artery to perfuse the graft and so forth, but the venous connections is key here, actually, because the problem, one of the big issues here is drainage. How do you, the edema that you see in some of these pictures, you see if you Google the internet as to what the results look like, there's a lot of the stuff that goes into is how do you make sure that it drains properly? The lymph channels are of course interrupted, so you really have to have good venous connections for the stuff to work. And so that's, I think, where one of our role is understanding that. It becomes very important. There's different protocols. This is our protocol at NYU. So our evaluation for the recipient includes a CTA of the head and neck. You get the mask phase. You need to have it's good to have that venous phase is very important, because again, veins are important. For catheter angiogram evaluation, this is what we do. We want a really good quality angiogram, general anesthesia, paralysis, apnea, whatever. All of the stuff that goes into getting a good angiogram. Some of these people have allodynia and hypersensitivity in their tissues, the scar tissues of the face. So injecting contrast into their external carotid is not a pleasant experience, as they know from CTAs, for example. So it's good to have anesthesia. You want to be conscious of ALARA, of course, because again, a ton of radiation in the post-op period and the pre-op period. There's been a lot of exposure. So and the evaluation includes generally you don't have to be subselective, or we are not subselective in these vessels. A CCA view or maybe proximal ECA view is good. And then depending on what you might, or whether they're going to be transplanting, you might need to do the verts, whatever, these other vessels. But in general, CCA views are actually usually sufficient. The goals are like this. So what primarily from a surgical perspective, one of the key things is understanding the anatomy of the carotid bifurcation. Is it high? Is it low? What the branching pattern is like. One of the concerns is what kind of anastomosis is done. Is it end to end, end to side? The end to ends are usually favored, at least here. If you're going to do an end to end anastomosis, you have to cut the external. Like where you cut? You cut above the facial lingual trunk, below the trunk. That's kind of like how much trunk do you have? So a lot of that's obviously, as you know, is very variable. So that needs to be evaluated on an individual basis. Lingual supply is important. We'll get to that. Of course, that's the one area that has potentially less collateral support in the recipient than other areas. Generally, as you know, everything is like super collateralized in the face. But the tongue, sometimes you can get into trouble. Venous stuff is like this. Like you want to know, are there two jugular veins? Did they have too many central lines and one of them is gone or something like that? What the major drainage patterns are and what the variants are. And that's individualized, but very, very key. In the donor evaluation, same thing. CTA head neck, catheter angiogram, same stuff. The only difference is these donors are generally donating not just their face. So there'll be like all kinds of organs. And so contrast dose becomes like one of these limitations. The latter, perhaps not too key, but the contrast dose is important. And so we generally just do common carotids. You don't have to worry too much about these other vessels. In the evaluation goals, very similar, like whatever, looking sure everything is the same. Looking for injury is important in terms of vessels. Lingual supply is not too important here. On the venous side, it's very important to understand variants. Because they have to dissect the veins out too. And you don't want to get into a situation where, as a result of a variant, a vein that is not expected to be there, but it in fact happens to be one of the major draining veins of the tissue that's harvested, is taken, is inadvertently cut, and that becomes an issue. So you really want to understand on the recipient, in the donor, really want to understand how the stuff drains. The post-evaluation, like again, like same. You want to compare apples to apples, CTA, head, neck, catheter angiogram, same thing, general anesthesia, paralysis, And so you want to evaluate, of course, the perfusion of the graft, and also sometimes like what the rearrangements are, how is the face of the recipient supplied, depending on where the ECA is ligated. And so that's what you do. Alara, again, is, of course, important. And so the evaluation goals, a lot of this is driven by obviously by clinical status. If the graft is perfused, one way or another, it's perfused. If the tongue looks okay, then somehow the tongue is getting blood. But the details of that are important, I think, in understanding and planning and planning the next ones. And so a lot of this evaluation really is as much as understanding what's happening here as understanding what maybe took place in the surgery and how to go forward with that. This is another pain point that I think we keep stressing, is like you kind of want to see what the venous drainage is like, because that's something that's that's important. So we'll go through questions so far. Any questions? All right, so we'll go through like one case and then a couple of other points to reinforce what's going on. So this is, whatever. These are images of this is the recipient. The recipient gets a CTA evaluation. You see the venous phase is, obviously the arterial phase is usually better. So you start with the basics, like you go through the axis, like the reconstructions are great, but your service to the transplant team and like your value is really in understanding the vessels. And it's a lot of it's just common sense. You don't have to know the minutiae of anatomy or anything like that. It's just understanding where the big things are and where they go. So you trace like the angular veins, you can trace them down and just regular axial cuts. You want to see like how are they draining? Here's the sternocleidomastoid. You know, is the facial vein going to drain like superficial or deep to the sternocleidomastoid? That's important, right? Because this is very superficial. When they're removing these tissues, what if it gets cut? You know, so you have to like just basically point out the main patterns that exist. Okay, now that's the recipient. Here's the angiogram. So like big field of view, you know, less radiation, just a common carotid injection. Here's arterial phase, venous phase, got a jugular vein. Like here's the lingual artery. Lateral views, you see if there's a facial artery, still remains. You know, arterial phase, venous phase. So just big pictures. Here's another one on the left side, same thing, looking at the left jugular vein, a little bit smaller but present, so like a very typical kind of arrangement. Lateral, a little bit more drainage into the anterior jugular system, you see right there. Important to have these unsubtracted views because you want the landmarks to be seen next relative to the vessels, like where's this bifurcation. This is what's important, like the surgeon wants to know how much of a trunk do you have here? Is the facial lingual trunk, common trunk? How much do you have? Like, do you have like a centimeter or so? If you cut below the facial lingual trunk, are you able to like, is there a good chunk of anastomosis available for the donor tissues to do like an end-to-end anastomosis? And generally speaking, like when we talk about perfusion of the face, you all know that there's a lot of collateral support there. You can, in vast majority of cases, you can ligate bilateral externals proximally. Nothing is going to happen to the patient. Very unlikely to have any kind of issue related to perfusion if you were to do like a proximal ECA ligation, blood anastomoses, and so forth. So this is again, this is like the recipient evaluation. We did the vert in this case. You see the jugulars. Now, like there's some things you want to know, like there's going to be like an extensive transplant. So you want to know what's going on in the posterior neck tissues. So there's a lot, as you can see, there's a lot of like vertebral supply of what might be traditionally the deep cervical territory, which is in balance with that. So this is just one of these anatomical points. The vert supplies a lot of that. So what that means is that the deep cervical doesn't do a lot. So all of that is like sort of basic balance, like vascular balance anatomy we always talk about. We got a little bit more of the ECA supply here because we wanted to see the veins, whatever. That's not really critical. So you see how the face is draining, venous drainage. So here's an external drainage. Here's into the anterior jugular confluence right here. Here's some drainage going up. So some of this is just like modified by the injury and the subsequent surgeries. The veins here are like not exactly normal, but a lot like more of the face probably is draining up into the ophthalmic system a little bit more than typical, but that's not too important. You get these volume rendered views. These are also good. The surgeons like them, of course, and we like them too. You can see the relationships nicely. You can understand, like, for example, here's a nice facial artery. Here's the angular artery, so facial dominance. What that means is the transverse facial is it's reasonable size, but not too big. So a lot of it is just like understanding basic balance, what the facial artery is in balance with. More important for the donor. Right side, same thing. We look at these things. Now here's the donor. Now in the donor, probably more than the recipient, it's important to understand the veins. You really don't want to get into the situation where the veins are injured while they're trying to get the face from the donor. So again, like you just take the major veins and you trace them. Here's angular. This is like superficial temporal external jugular venous system. You kind of trace them. You see on the right it's a little smaller, on the left it's kind of bigger. This venous confluence, you see that this is the sternocleidomastoid. You see where the anastomosis is with the external system on this side and that side. So this is just like important stuff to pay attention to, and that becomes key. Angiogram, typical, like, so this is usually these patients have some kind of like head injury or something going on in their head. So this is a head injury patient. This was like a cranial, like basically a decompressive attempt that was made. So you see on the right side, common carotid injection, typical like pattern of like lack of intracranial flow. So you just see the external system. Here's the venous side, lateral view. There's like a laceration back there that they had stapled. The superficial temporal, so the parietal branch is missing because again, they were like trying to open the head. You want to see injury patterns and so forth. So you see the venous drainage here. You appreciated that. You want to see that on the CT perhaps before you get into the angiogram, correlate them, make sure that they look about the same. There's no surprises. So this is like a typical venous drainage pattern of the facial tissues, nice facial artery. So I don't think there's issues on the artery side here. You get these volume views. Left side, same thing. Injection, just a common injection. You're not using too much contrast again. Here's the venous side. So you see on this side, the veins are bigger. Why they're bigger on the left? Because they've cut some of them on the right and like cutting the skin to get to the skull. So more drainage is happening over on the left side. But the veins, the facial veins are okay on the right side. So here's your venous views and the volume rendered ones. Now this is the post. So the post, when do we get the post? We get the post whenever the surgeon thinks you should get the post. So generally that doesn't, if everything is going well, if the graft is perfused, then you don't get the post for maybe a month later or so. At that point, there's a lot of things that happen after when a transplant is done. Like there's a tremendous number of stuff on the non-vascular end that has to happen. They have to they get these little, they go back to the ORs for like, sometimes there's like pockets of fluid or whatever or something else that needs to be touched up. So it's, they spend a decent amount of time in the hospital. By the time there's no vascular issue, they come down at some point to see what's going on. So this is a post view. You can see that in this patient, like for example, if you look at this, there's this like strange vessel here. What is that? Basically what happens is they've dissected more of the facial tissue. So this is like the external carotid artery of the donor. This is the facial artery, and both of them are anastomosed here to the external. Here's the venous phase and the lateral. You can see that this is the donor facial, donor external. You can see that this was an end-to-end proximal ECA anastomosis. You don't see any branches of the recipient, right? The native facial, lingual, whatever. All these ECA branches are not here. Why? Because they did a proximal cut. And so we're going to see them from somewhere else. So this is a good picture, right? You have this facial artery, check. Perfusion, check. Venous phase, nice drainage. Look at this. Like you have nice venous drainage of the donor face. You know this is the donor vein because you only injected the donor artery. And so you know that these are donor veins and they're going down fine. So this is like a good one. You get one of these, of course. Take a look at whatever you want to see what it looks like. Here's the left side. So on the left side, you have a little bit of swelling here. You see how, so maybe there's like some kind of fluid pocket there or something, but there's more edema at this point right now. This is about a month out. Again, there's like external facial that's been harvested, plugged into the jugular system here. Lateral view, same thing, like everything checks out. You have good drainage. It's an end-to-end proximal anastomosis, which implies that basically what that means is that you disconnected the externals proximally, and usually that's not a problem. There's no perfusion issue in the recipient's like tongue or face or what's under the graft. So this is working okay. That's working okay clinically. Here's that. Now, where do you if you want to, do you want to look for these collaterals? Do you have to? We do, because I think it offers like important insights into what's going on. So a lot of them come from the vert. Here's a left vert injection. You see a typical reconstitution of the external system through the vertebro-occipital anastomosis. Here's the lingual artery, for example. You see the left lingual. That's this arrow. This is like, when you look at this, you see something here, like maybe this is some kind of stenosis or whatever. We can take a look. So this is the lateral view again. So here's your vertebro-occipital connection. And from that connection, here's the recipient IMAX, the ECA, the lingual trunk, and so forth. This is the volume rendered views. Now in these views, you can look at them, you can do whatever. Here's the lingual trunk. Now when you look, you do identify that there is an issue. There's this clip sitting here. And whether because of that or some other reason that just happens to be nearby, but there is a stenosis, a significant stenosis related to the facial lingual trunk of the recipient. There's no clinical issue, so this is something that you want to kind of take a look and see. But if there is an issue later, you might be better able to deal with with knowing what's going on. So you can get an angiogram, understand it a little bit better. Maybe there's obviously still antegrade flow into the lingual system. Here's the right vert injection. So we go to the right again, whatever, right vert, all these connections, same, similar kind of like disposition. Here's the view on the lateral. So again, vert, occipital, external, whatever, so forth. Now you look at this picture. Here you want to like take a quick peek, and if you do, you realize that there is something missing. And what's missing is the lingual artery here. This is the facial. Usually like you see two vessels. Well, you only see one. If you go back here, there's like the tongue is here. You don't see anything. Okay, so what happens? Now, normally, if you have one lingual artery, usually the other, like one is enough. It'll cross-fill the other side. But if you go back here, a little bit like that, where we showed you this lingual artery from the left, you don't see really much of a blush here on the right side. Maybe just not a good injection, like you don't need a subselective thing. I don't know. But something to keep in mind. So the tongue is not falling out. The tongue is not swollen. So we know it's getting blood flow somewhere other than this. And then you have to do a little bit of searching. And like in this case, you find it here. This is a kind of like this really main, like cervical, like injection. This is like a common trunk of this big vessel. And part of what's happening is you see the lingual artery here through some anastomosis. It's related to the inferior thyroid system. It's not really too important how it gets there. You don't have to name the vessel necessarily, but you do see that there is this little vessel that's reconstituting the lingual artery on the right side. Now, here's the lateral view of that. So you see that's very anterior, like an inferior thyroid would. And that's coming up here and coming up to the tongue. Now, is that important or not to know? It is important. Why is it important? Because the guys might have like another 10 surgeries that need to touch something up somewhere here or there. The surgeons probably want to appreciate that in this anterolateral neck region, there is a vessel that's like really trying to feed the tongue. And so you have to be careful if you're doing something there. So these are like, you can get views, of course, like the rotational views that can give you, obviously the cross-sectional data from that can be even more instructive exactly where this anastomosis is, particularly so that it is preserved in the future interventions. So this is like the kind of stuff that's more or less like a preview or one view of one case of what can happen. Any questions so far? Okay, so now we can go back to show a couple of other things. So this is a another case, just a recipient, a different kind of injury in this recipient. So this is the pre-evaluation. You can see, for example, that in this particular person, part of the injury like messed up the facial artery here, so there's an interruption. Here's the transverse facial that's like growing up and it's reconstituting the facial artery here. So like something that, again, they need to be aware of what injuries might have taken place as a result of what happened to this man. The donor here, just whatever, this is another view of reconstructions. But in this donor, this is an example of something that was actually important in terms of venous anatomy. You can see that if you trace these veins, the angular and the facial veins, that there's a variation here whereby a lot of these veins are draining like up anterior here. You see that? So this is the anterior jugular system. Particularly here on the left, that's the main drainage. And that's important because as they're harvesting the facial tissues, if they don't know that, there's a decent chance of injury to that vein. They may not be looking to where that goes, and that needs to be preserved. So that was key in this particular person. You can see how there's a trach going in here, like thankfully the veins are on the side, but sometimes that stuff gets injured, like these veins. If someone's getting like a slash trach or something like that, sometimes there's a lot of bleeding that happens from these ones. So here's a angiographic confirmation of that. It's very important. It's very good to look at the CT. When you have a CT, you can really understand these veins, I think, probably easier, or at least you could, to me, I think that gives a ton of information. Now, when you look at this angiogram, you see the correlation of that. You see the drainage of the facial tissues on the left. So you see that there is this vein, that's the anterior jugular vein. Now that vein is actually going to join the subclavian system all the way down there. There is a little connection to the external jugulars connecting to the internal over here as well. And you can see that if you look at carefully on the CT, you'll recognize that also. Here's the lateral view. You see all of that going anteriorly, right? Okay, so this is the post. So in this particular person, just to illustrate some of the spectrum of things that we run across, here's an injection of the right common carotid. Obviously, like early view, late arterial, parenchymal view, venous view, right? What do you see? You see something interesting. You see this cross flow to the side. So this is, again, this is the donor facial stuff. And you see this cross flow to the other side. So something is going on, right? There's some kind of, there must be a flow constraint on the left. There's something probably not exactly right with the left side if it's going like this. So that's okay. So we're going to keep that in mind. This is the lateral view again. So this is again like an end-to-end anastomosis. So here's the facial system of the recipient, of the donor. A little bit more edema here. You see how the venous drainage is not as good as in the first case. This was done a little bit earlier post-transplant. So some of it has to do with timing, but you can see that the veins are not like draining as well. So we get like, we want to get some views here. You see that there's some kind of stenosis here. So maybe there's, for whatever reason, this vessel doesn't look very healthy here. It's probably, I mean, we're not expecting any athero here or anything like that. So this is maybe related to the manipulation, hopefully temporary, because it's not, I don't think it's potentially not a fixed issue. But there is a flow constraint here in addition to what's going on probably on the left. Volume rendered view, again, you basically, like what looks like is the whole, like big part of this graft is supplied from one vessel. The right side looks like it's supplying a lot of the left. And indeed, when you look on the left side, something happened here. We don't really know what. There was some, you know, going back, like a surgeon might think of what might have taken place, but obviously there's some issue with this facial artery. It's not doing very much. Proximally, the anastomosis looks good, but there's an issue a little bit more distal. So again, like what do? Well, a lot of, obviously, this is clinical decision making. If the face looks, if there's no vascular clinical issue, then you're going to leave it alone and see what happens down the line. But it does speak to like one of these, there's a little bit of like, I don't know if it's a controversy, but there's a question in this developing field, like how many anastomoses you need and what's enough. And so this is like an illustration that even if like you lose one engine, you could keep flying, given that there isn't like a functional anastomosis on the other side. Obviously, it can keep going. This is a delayed. So this is the same person comes back a year later. And a year later, you see what often happens in the facial vasculature is that things get better. So there's a frontal injection. Now you see a lot more in terms of the flow. Look at this. This is the left side. The artery is back and back in a very nice way. You see how much it supplies. There's like, here's the lips, upper lip, lower lip, labial arteries, angular artery, all of that stuff. Nice venous drainage, right? Look at this beautiful venous drainage going in here. And this, like functionally, this guy is doing very well. Here's the right side again. Things are looking good. That's the volume rendered view. You see the big difference, right? So the big difference is like this. Now in this guy, again, like everything is going fine. Here we took the lingual artery for surgical reasons, the lingual was ligated over here. And so you see like a little bit on the volume rendered view, the lingual extending to the other side. So that's plenty to supply the tongue. And that's the left side of the volume rendered view, showing that the artery is like nicely recovered. So the conclusions are, I think, I mean, some of it is obvious, but I think it's important to have, like, very important to have good technique, especially if you want to be like helpful to the surgical team. Really want to present pictures that are understandable, easily interpretable to somebody who is not living in the vascular world necessarily all the time. Things have to be looking like you can see them, and it's important for presentation as well. If you're showing this work, you want it to look good. A lot of it is basic vascular anatomy understanding. Venous evaluation is really critical. So if you're getting into this, if you're part of this, you have to understand that as much as arteries are important, veins are equally important. And if there's a venous outflow problem with the graft, it's a big problem. And it's not like necessarily easy to fix. So with that, I thank you for your attention. There's actually one more thing I wanted to show. We didn't really touch upon this, and I think so far our donors have had relatively normal vascular anatomy. But I think going forward, like if you're studying, let me see if I can share a different screen here. Let's share this one. Like if you're studying the anatomy of the facial vessels, like everything, we talk about the balance that exists, right? So everywhere there are multiple sources of supply to the face. What that means is that they're going to be in some sort of balance. So maybe the facial is very big, maybe the facial is not very big. So far, these people have had like a big facial artery, which is very helpful. But this is not a face transplant. This is just an angiogram of a patient that happens to have a relatively smaller facial artery. So what does that mean? They have a bigger transverse facial right here. There's an infraorbital artery. So the distal infraorbital artery, once it emerges from its foramen, can supply a lot of the angular tissues here, right here, that the facial might do. So something to keep in mind. We have, let me see if I can show you. So on the facial artery side, same thing, like here's somebody who has dominant facial anatomy, right? But you go down, you find an example of somebody like, again, like this person, they don't. They have a smaller facial, they have a bigger transverse facial, bigger infraorbital, and that can be angiographically evaluated as well. Like, so someone that looks like that versus somebody's facial that looks like this. It's relatively quite small. So all of that you want to keep in mind. Having said that, we're gonna stop, pause, and answer any questions you have. Any questions or comments? Please, please speak up.
There's a question from Dodi on the chat, Max.
Would you do a late angio follow-up from Dodi? So I think we usually, so what Rodriguez does is he usually brings patients back after about a year. And so typically we will have done, so far we do usually 2 angios in the post, one about a month out and one about a year out. But it depends on other factors. So this, like one case I showed with that facial that wasn't filling, that's how that played out. So especially if there's some kind of question, it's interesting for us to know. So far we've done like a month and a year.
He asks why.
Why? I think it's I think why is probably for a combination of reasons. Is one is to understand what to correlate the appearance with the like what kind of healing did we achieve? How do the veins look? I think from a surgical perspective, it's a lot of it just has to do with understanding how like the disposition ended up being. And I think going forward also what happens is these, like the NYU effort is about 3 years old. Some of these people in the later phase can get into issues related to like rejection. And so that I think you want to establish a baseline. That's, I think, is one reason that I know of, that you want to do this. If things go wrong later, you want to see what's going on. So far this like, I think we expect probably that the facial transplant thing is going to keep growing. There's about 50 of them done in the world up to date. And the major players, usually the countries where they do them, France has been a leader, Turkey, some in Spain, in the US. And I think it's picking up, but it needs a big team to do it. They have to be like, obviously, people involved that know the immune system, and the transplant network has to be established. But so far, most of them have been successful around the world, depending on how you define that. I think the 3 we've done here have been successful by anybody's account. Okay. Anything else? If there is no other questions, then we have a presentation from Dodi. Dodi, thank you very much, as always. Go ahead. I think you're good to go.
Should I start? Hello, everybody. Let me see. Okay. If I can.
Let me
allow
see.
me to.
Yeah, hold on. Sorry. Let me see. Yes, go ahead. Yes. Okay, you should be good now.
Okay. This is a simple something which maybe can open major discussions. So I just wanted to show you a couple of cases. And of course, there is a long list of the limits of what we do. And in this long list, what I chose today was to speak about follow-ups and statistics. And so I show you a couple of cases. This is a 59-year-old lady with a symptomatic left intracavernous aneurysm. You can see a little bit the mass here, but better the angiogram here. She was symptomatic, and a few years ago, in 2009, we were experiencing, well, there were the first experiences of flow diversion, and we used the silk in this case with a 4x20 silk to try to see if it works in this kind of aneurysms. And at the same time, we could see that on the opposite side, apart from a trigeminal artery, we could also see a small paraclinoid aneurysm, very small. At the 6 months follow-up after flow diverter, the artery appeared like this, and we were very happy to see how this worked and flow diverters work. And on the other side, of course, we checked again, and there was the same small paraclinoid aneurysm. Would anybody have treated this? Of course, we didn't. We thought we shouldn't, but I don't know if somebody in the world would prefer to do it. The most important thing, of course, was that the aneurysm deflated and shrank, and so the cure was complete. So all is good, and we were happy, and we decided she was cured and she didn't need any more follow-ups. But then 11 years later, so recently, there was a subarachnoid hemorrhage, which appeared a little bit more on the right side. So on the opposite side compared to the treated aneurysm, on the side of the small paraclinoid aneurysm. And what did bleed? Well, the angiogram showed that where we placed the flow diverter, the aneurysm is okay. The artery looks a little bit funny, but we might talk about this in another time. So intracavernous aneurysms tend to have a different life than other aneurysms with flow diverters. And on the right ICA, of course, there was something different. There was a posterior communicating aneurysm which bled, which we treated with a few coils. And now I want just to show you what happened in this region. So in 2009 and 2020, the right carotid on AP view, lateral view, and somewhat oblique view. So you can see that there is an aneurysm which is not the paraclinoid, which almost disappeared by itself, I don't know. But the aneurysm that bled was a different one, which was not there in 2009. So this raises a couple of points in my mind. That, of course, treating the small incidental aneurysm paraclinoid would not have helped with a 11-year later subarachnoid hemorrhage. And this casts a little doubt on the usefulness of treating unruptured aneurysms. And second, that if you look at the statistics and the papers where they collect all the cases, where they follow the cases with small incidental aneurysm, and then at a certain point, some of these will have a subarachnoid hemorrhage. And of course, they think that the hemorrhage was due to the aneurysm target, which is the one you follow. But in fact, the hemorrhage might have been from a different aneurysm, which is the one you never saw before. Second case, in 2011, subarachnoid hemorrhage from a pica aneurysm, which is this, and we treated, as you can see, with coils. And 9 years later, a second subarachnoid hemorrhage. So what happened? This is the CT 9 years later, subarachnoid hemorrhage. The pica aneurysm seems okay. but there is something else up there at the level of the anterior communicating artery. And you can see it here. Can you please take myself away from the from being a host of the meeting? Thank you. Anyway, so we, of course, also in this case, we treated the small anterior communicating aneurysm with coils. But how was the anterior communicating in 2011? Like this, meaning there was nothing. So the take home for me is that bleedings from de novo aneurysm are not negligible. Everybody knows this. But when you see it again and again, you start thinking, well, how can we, treat patients rather than aneurysms? The ISAT trial, sorry, I tried to take this away from Maxim. Could you just make me not the host of the session?
Yeah, sorry, Dori, I did.
Okay.
You're not the co-host anymore.
I don't know what that is. Anyway,
If I
sorry about that.
Make you host. Let's make you
It's a ghost.
What
I'm
happened?
sorry. But so in the ISA trial, there was a follow-up, and it was known that there were some rebleeding in that cohort. And half of those rebleeding were due to the rebleeding of this aneurysm, which was treated during the trial. You can see it here, where there were 24 total rebleedings, and 13 were due to a rebleeding of the same treated aneurysm. But 10 were due to another aneurysm. And very interestingly, just 4 were from a pre-existing known aneurysm known to be there, and 6 were due to a de novo aneurysm which was not there before. So that it was a little bit higher, the probability to have a rupture of an aneurysm which was not there before. So again, the bleedings from de novo aneurysm are not negligible. And in long-term follow-up reports, these cases, if not checked, would be considered as a rupture or re-rupture of the target aneurysm, not of a new aneurysm. So statistic of unruptured aneurysm or repeated subarachnoid hemorrhage should consider this possibility. Could we have prevented this outcome? With follow-ups, of course, but when and how? There wasn't one intermediate follow-up in 2015, 4 years after the original subarachnoid hemorrhage. And this is the anterior communicating at that time. You could not really see an aneurysm there. When you do the reconstruction, well, looking well, there might be suspicion of something, but which was not really, of course, reported. There are so many little suspect bumps in the vessels reconstructed. And so it was not reported, but if it were reported, would you have treated that? Of course not. And so you would have made a follow-up, and when? So when did it become the current ruptured size? It was 1 year before, 1 month before rupturing, 1 week, 1 day, 1 hour. So when should you make a follow-up? And does it make in follow-ups being in some way reassuring due to the fact that really we don't know when it happens? So the debate for me is statistics may be misleading. How useful is it to treat an unruptured aneurysm when the aneurysm which will rupture is not yet there? And how useful is to make follow-ups when, of course, you make the follow-up and then a little bit later, you will have a big change in the shape of the aneurysm. And the conclusion is that we need to learn to live with uncertainty. And I really advise you to read this book by Gerd Gigerenzer, which is about risks. And since all we do and all our job is about, is concerned of risks, and we have to think about risks and relative risks and comparing risks, well, knowing about risks is important. So that was what I wanted to say. Thank you very much.
Thank you, Dodi. Just a quick before we get into the discussion, Dodi, since you're the host now, if anybody is in the waiting room, you have to let them in. If you see anybody waiting, I can't see if there's anybody waiting. Or if you want to give up the host back to me or to somebody.
How
take care of
should
that.
I do it? Participants. Okay. I don't know what I should do.
Okay. If you see anybody in the waiting room, just let
Yeah. No, I don't think so.
All right.
Okay. But I would like not to be a host.
Yeah, this is Kittipong here. I'm co-hosting too, and I can see the people in the waiting room, so don't worry about it.
Wonderful.
Okay, thanks.
Yeah.
All right, so listen, okay, so this, of course, we could talk about this for a long time.
Yeah.
Anybody, any comments? Like, this is very important, of course, and we need to, I think we need to talk about it.
Thank you, Dottie. Can I make some comments? Because in Japan, we do follow-ups like with MRIs. We can do MRIs as many times as we want, actually. So we usually do annually for every patients that they're still around the area. At least once a year, an MRI follow-up for like indefinitely. It's we have found not that many cases, but a few cases of de novo aneurysms that we intervened before they ruptured. But I don't know if it's really useful. We follow up like hundreds of people, but only found a few. I don't know. If it's worth the worth the cost. I don't know.
Yeah, that's also the point. It costs a lot of money, and it depends who pays for it and who earns the money also.
But that does raise the question of, like, how often to follow up on patient. Okay, patient that had a subarachnoid hemorrhage, what kind of follow-up, or how, these are patients that always ask, okay, will I develop another aneurysm? Will I, and they are concerned indeed. What's the best way to follow these patients? Like, how often? These are obviously two rare examples from a large practice, and probably the exception.
I'm not sure. They just came in the last 2 or 3 months, so not really. But yes, of course, the cluster. But the point is that we, as doctors, we should cure patients. Saying cure means, okay, you're cured, you can go home and have a normal life. Consider yourself cured. And I think we should really say at a certain point, don't think anymore about this. And if something happens, which may happen, of course, it may happen also in many other issues in your life. So learn to live with uncertainty. You cannot be sure that everything will go well forever, but you don't know where the bad things will come from. And so just don't care about it. Forget about the bad things that can happen, because otherwise you will go crazy. So that's pretty much my point. Learn to live with uncertainty.
I think it's congratulations, Dodi. Again, this is an interesting topic. And I think it's particularly relevant because in one sense, it validates one of the theories of the ISUIA trial, where they looked at, there was always a question of if you make a statement that small anterior circulation, incidentally discovered aneurysms have a very low likelihood of rupture, how does that sort out with the empirical observation that the average subarachnoid hemorrhage aneurysm is around 5 millimeters. And so the theory that evolved out of that was that aneurysms form relatively suddenly, and either they rupture or they don't rupture. And so if they form and don't rupture, then they take on this life of a small incidentally discovered aneurysm at some future date that has a low likelihood of rupture. But then the ones that form and rupture at that time are what we discover as patients coming into the emergency room with a small ruptured aneurysm. And so I think it's actually, kind of a reassuring observation that you've made.
Yeah, that's exactly my thought. And that's the reason why I tend not to treat most of the small incidental aneurysms, really almost 90%. And I try to reassure the patients, telling them that, well, it can happen. It's very rare, and it's something which relates to all the risks we run every day in our lives, just going around with cars, trains, and planes, and descending the stairs of our home, and everything that we do every day when we wake up and go out of the door, or even if we stay inside the home, something may happen. And we think today in our Occidental world and philosophy is that we should be able to control everything. And if something goes bad, well, somebody is responsible for that. And that I don't like.
Let me show, Dodi, I want to just share a screen for a second. Let me see if I can show these cases, because I think it's not, can you see? Let me see which screen you're seeing now. Okay. Are you seeing the case, the neuroangio case? Was the CAT scan and hemorrhage? Yeah. Can you see that? Okay. I think
Yes.
All right. So just to emphasize, and it's a related point, but an important point, I think, for the audience is that as much as there's this species of new aneurysm rupture, which is what we're talking about. But just to bring back the idea that, of course, we also live in a world where partially treated aneurysms can re-rupture. And I think that's just to complete the spectrum of what happens in terms of delayed subarachnoid hemorrhage. And that's, as we all know, it's not just coils or whatever, clips do that too. So here's just an example, these are just examples of patients. So here's bilateral clipping, there's a clip. And if you look here, you can see that it's a re-rupture of a previously clipped aneurysm. You can see that little guy behind the clip right here. That was just to show that we treated that with coils like this. And of course that happens with, let me see where we have that. There's of course a post-coiling that happens with that too, as we all know. So here's another one like that, and whatever, here's a PCOM, there's some coils here, big recurrence, recoiled, and then ultimately we ended up piping that in delayed fashion to make sure that it stayed closed. So I mean, obviously, like in all of these, in both of these cases, the issue is really follow-up. And I think to my feeling, like, I think it goes back to like, what do we do about the follow-up of these patients? I too feel very conservative about treating small and ruptured aneurysms. I mean, our practice, if somebody has a ruptured aneurysm, then we go after the other small ones that are unruptured in belief that maybe they have a slightly higher risk of rupture too. That doesn't address the de novo ones that you've shown. That's the main question. So I don't know. I think in the one sense, yes, like anything can happen to us, right? On the other hand, from a patient's perspective, like, you know, they've already stepped on this banana peel once and it ruptured. Like, you can say, well, okay, like you're gonna, like, what happens down the road? Like, they are obviously sensitized. We can tell them, we believe you're cured from this aneurysm that ruptured in you back then. But do you have to, like, are these patients more, like, I'm more with Kitty Pong in this. I think a follow-up of these patients with periodic MRAs, to me, is reasonable. I don't think there's data how quickly we have to follow them, how quickly they arise and grow, might happen in between the follow-ups, who knows? Lots of who knows, right? But I'm more into the camp of trying to follow them up somehow. Of course, a lot of people get lost, right? What happens is, okay, follow up. How many times do you want me to do this? And so that's what happens to, like, most of our patients are really, as much as like yours are a really point of discussion. Like, I think that the patients that re-rupture in our experience have been the ones that just were like, didn't come back for their follow-ups and they just re-ruptured because they weren't completely treated. How to deal with that is like medical as much as other issue. Any other comments? Any questions?
Yeah, Max, it's a complex issue because, as you know, like when we find an incidental aneurysm, a small one that we're not going to treat and we're going to conservatively manage it, at least here in the States, it tends to be imaging follow-up at defined intervals. Initially, it starts out being sort of a repeat MRA every year to see if it's growing. And there's a presumption that if it's growing, I guess that means it's unstable. And so you can't default to the notion that it's, you know, it's in somehow like an aneurysm less disposed to rupture. But that's also not a proven observation. But, you know, like with time, you know, we sort of draw that out, and then maybe it's every other year that they get an imaging study if they go several years without any change. But that's all sort of just anecdotal. I actually just last week was discussing a patient that I treated 5 years ago with treated an aneurysm, and she didn't have any other aneurysms, but she had kind of a fenestrated ACOM anatomy, and we, I don't know, I decided at 5 years maybe it would be a good idea to survey the cerebral vasculature again, and then we ran into the insurance companies, and now they don't want to pay for surveillance of a person, you know, with a history of just one aneurysm that now is treated. And so, you know, it's a complicated societal kind of issue. And I guess a lot of what Dodi is alluding to, this kind of assessment of risk and who takes the risk, you know, that kind of has to be sorted out. But very interesting topic.
So just to throw it out there, over the years, we see like a trickle of effort to like better define risk or risk stratify these patients, right? People present vessel wall imaging, for example, or some other kind of like analysis, like maybe flow analysis of these things. Any comments where we stand on that? Do we think like, obviously we need better risk stratification. Size, location, like that's great, but it's really primitive, you know, in the big scheme of things, I think. but it seems like the vessel wall imaging progress has, I don't know, has not delivered as much as maybe people had hoped. Did anybody know anything else that's going on, or comment on how that's evolving?
Well, for me, even if you take that at face value, so it's a moment where the aneurysm, there is an inflammation, an inflammatory process of the vessel wall, of the wall of the aneurysm, which might be okay. Then you have to think, well, not all inflammation will go over to rupture. And it could just be, inflammation is a transient event in all over your body. You have it, and then 15 days later, usually you don't have it anymore. So is it really a reason to go on and treat an aneurysm just because there is an inflammatory process, or it's just one of the many times where this aneurysm will have an inflammatory period in its life and nothing happens? So really, I'm not really convinced about it yet.
We here, so in terms of prevention, like most people in the United States don't recommend like a baby aspirin for someone with an unruptured aneurysm, but I know that some people do, especially I think more commonly in Europe. Can anybody comment on what's going on in that regard? Yeah, I mean, here there's like an 81. I think in Europe there's a 50 milligram dose. There's been a little bit of a shift away from taking a baby aspirin in general, not in the aneurysm world, but in the cardiovascular world in general. There's like some data that still the risk of bleeding, even though small, these are all like small, very small risks, small benefits. So I think less people are taking baby aspirin now, just as a knee-jerk kind of reaction if they have any cardiovascular risk factors than they did before. It's always humbling how much we don't know, and really what we need to continue to learn. Okay, anything else? Anybody have any comments, cases? There's a question, I think, from Yinlun Edwards. Do you use vessel wall imaging in your follow-up for aneurysms? We make decisions of treatment based on the findings of vessel wall imaging if the aneurysms not quite meet the size criteria that interval growth. So so the question is, we don't, like, I think it depends on the group, right? So yes, occasionally we have, but mostly like just based on like a particular aneurysm that for whatever reason we had felt we wanted to see what that looks like. But so far I have not made a decision. I have not changed the decision to treat or not treat based on vessel wall imaging. And for various reasons, I think a lot of them in the unruptured group just kind of look very bland. Others just haven't. So I have not. Anybody else want to comment on that? Okay. So if there's nothing else, we can end early. It's 9:15. I think we're good to go. If anybody else has anything, we can stay. If not, then thank you all, and thanks for coming. We'll hopefully put this up on YouTube. It'll be available to view. So if you know somebody who hasn't joined, they can see it. They can see the recording. Thank you very much, Dodi. Thank you for the presentation, and thank you for the discussion. So have a good rest of the day or evening. We'll see you next time.
Ciao, everybody.